My name's Morgan Rain. I'm a GP in Victoria, and I also work with the Victorian Specialist Consults. Next slide, please. And I know people may be joining us from all across Victoria, potentially out of state as well. And so I'd like to acknowledge the traditional custodians of the land on which our health service is built, those of the Taungurung and Wurundjeri people. And we acknowledge their connection to land, waters, and community. And we like to pay our respects to the people, the cultures, and elders past and present for us, but also wherever you're joining us from today. So next slide, please. Very brief housekeeping. Everyone's on audio. The audience is on listen only. So if you've got any questions, pop them in the chat, and we'll be keeping them recorded, and then we'll bring them all up at the end. But there will also be question time, so feel free to wait till then as well. I'll send a specific link in the chat for the CPD certificate registration, but we'll also give a link at the end of the presentation that we'll leave up for a little while. And the webinar is being recorded, and if you want a copy of the recording, we can send it through as we just get the website where it's going to be hosted up and running. Thank you. Next slide. And for those of you who haven't met us before, Victorian Specialist Consults used to be Victorian Virtual Specialist Consults. The name has changed slightly, but the service is exactly the same. And what it's designed to do is to support Victorian community-based healthcare practitioners, specifically and mainly GPs, so anyone who works in the community, by providing access to hospital clinics and hospital specialists in a timely manner and as easily accessible as we can. And the structure of the clinic was co-designed with GPs, and it's really aimed to keep patients in the community with their GPs instead of people having to come into the hospital and then getting stuck in the system there. Next slide, please. So very briefly, the three main access models. The best one that we usually get fed back on is case conferencing. So yourself as a GP, hospital team, is usually very helpful. You can have practice nurse. We can provide someone like a dietitian or a diabetes educator, anyone in that team who would be beneficial to the conversation with you and your patient. There's the co-consult where it's just the GP and the hospital doctor, and then e-consults are new, and it's a short written communication. You do it on the website where it's more back and forth about just simple questions like, this is an example case, would you consider starting methotrexate? And then you get a bit of advice back on that. Next slide, please. We have over 35 specialties across adults and pediatrics available now. You can have a look at them on the website. Next slide, please, Hao. Would love to then introduce Hao, who's a geriatrician and palliative medicine physician who works at Northern Health and of course across Melbourne City Mission Palliative Care as well. And Hao is the clinical lead of the Northern Advance Care Planning program and helps run the Advanced Care Planning and Palliative Care virtual specialist consults as well. I've just noticed the hand's gone up from Padram. I'll just check if it's a tech issue. How can I help, Padram? Can you hear me at all? Not too sure. That's all right. Maybe just write in the chat if there's any issues. I'll hand over to you, Hal.
Thanks, Morgan, and thanks everyone for joining today. I am going to use Mentimeter. So for all you at home, if you can scan the QR code, and I won't know who's typing what, and there'll be a few questions, and we'll keep it a bit interactive. So if you can do that QR code, you only have 25 characters, so you can't write too much for all the questions as well. But this will generate a word cloud, and we can just have an idea of where everyone's at, what their roles are, and how we can best tailor today's session. This week is Advanced Care Planning Week as a national event, and the theme is Your Story, Your Choice. And one of the things that I will most definitely keep touching on is the importance of learning the story of your patients, your residents, as well as learning each other's story. And I think there's a lot to learn there, and it's really important for how we are able to look after those who trust us to and put us in those positions. So I can see lots of places all over, a lot of GP, which is great. I'll wait for a few more responses and then we'll move on. But this will be the same Menti for the whole talk, and so there'll be questions that come up as well. So you feel free to write whatever comes to your mind. It's great to see such a range of participants coming today and joining us. So I'll move on to our next one, and I want to know what advanced care planning means to you. And so you've only got 25 characters, so you've got part of life, great. Wishes, directive, empowering, really good responses. Choices. And whoever wrote less stress for families, that's right. Like one of the biggest impetuses for people to think about advanced care planning, think about having these discussions is because they've had to do it for their loved ones and they want to avoid that trauma or avoid that distress that they might leave onto their children. And so it's thinking about those key points in somebody's life that are transition points and when people are ready to have these tough conversations. Really great answers. So autonomy, person-centered, focusing on choice, wishes. Great. And last one for now is what do you want to get out today? Have you got some things on your mind that you've always wanted to know? Something that you've wanted to ask or not quite sure, but you just want to put it out there? Sounds like learning the basics, how to approach it, and just learning a bit more. That's the sense I'm getting. So I think we should be able to cover most of that. There will be time for questions, and I suspect you'll have lots of stories of your own that you may want to share as well. And so today, the things I want to focus on is understanding how the purpose, the process of advanced care planning. One of the things that we can all start is knowing who the medical treatment decision maker is and being able to identify that person. And then how do we apply this and put this into practice? So our northern team consists of myself, Ala Critchley, and Linda Hurd. We're a small team, but we feel like we have a mighty punch. We're based at Bandura, but we'll help service a larger area around our network. You can reach a lot of information is on our website. So if you Google Northern Health Advanced Care Planning, that will be the first link, and there'll be a lot of information there. But you can reach us at any time on that website. Advanced care planning, sometimes it's really, I think in general, people lump it with palliative care, with death and dying, and it's all put into this one big bubble. But advanced care planning is so much, can be all that, but it's so much of everything else. It's the conversations and communication that are the most important. It's understanding the things that are acceptable, the quality of life that's defined by somebody. And it's being able to plan for a time when you can't speak for yourself. In essence, it is informed consent. I think the questions we ask are who would you trust to speak for you if you couldn't? And would they know what you would want? And so we'll touch on how we can help identify that and how we would introduce advanced care planning. For me, as someone mentioned, it's patient-centered care, it's respecting autonomy, and it's also preventing those distressful situations when your family doesn't know the things that you would want for yourself. And it's preparing for those decisions because these are difficult conversations. These are confronting, emotion-filled discussions. I'd like to share now with you our Northern video that we've just created with some of our consumers, some of their voices, and it talks about some of their stories. And I think it's a good way of introducing advanced care planning tonight. So I'll share the video with you now.
Advanced care planning helps people think about, talk about, and document the values, preferences, and medical instructions that matter most to them. At Northern Health, we guide and support consumers through this process.
Well, in a sense, I see advanced care planning as a form of, perhaps using the word insurance, or self-assurance, perhaps even better. It gives me peace of mind with the knowledge that when something will happen to me, which invariably will, to everybody, I guess, in one way or another, I will be in a situation or a position to feel more at ease in my mind that everything that I needed to do for my situation is being taken care of, and there's no need for anybody else to intervene.
Brilliant idea, fantastic idea, because now they don't have to make the decisions, I've made it for them. So that they're looking at, okay, this is what mum wants, this is not what mum wants. At the last day, yeah. So it's out of their hands and it's in my hands. Gives me the freedom to say, my choice.
How did you find out about advanced care planning?
Well, one day I was at my friend's place visiting, and there was a pamphlet there lying around in the house. I picked it up and had a look at it. Weeks, perhaps months later, it came back into my mind, and I thought to myself, you know that pamphlet that you read? You should look into it and find more information. It was like a little bug entering my head. More than a curiosity, it was like you should really be doing this, you should be looking into it, like a little voice. And I did it.
I had a friend and she suggested when we went out for lunch that I also have a look into it because of our age. Being 78 today, and her as well, we thought we need to start getting things ready. We're not ready to go yet, but we need to start getting things ready.
Advanced care planning is very important in the critical care setting. For me as an intensive care specialist, when someone's critically unwell, I have to make decisions about their treatment very quick smart. And if I know that a patient has discussed with their loved ones in the past their prior goals and values and what's important to them, that information is really helpful to me when I have to make life and death decisions in a hurry.
What I do when I discuss the diagnosis and the potential treatments with a patient and their family usually, because there's someone coming with them, is for them to think about what their preferences are, what their wishes are while I go through the various steps, so that it gives them a chance to reflect on the options and what the outcomes and the side effects of those options are and how that fits in with what their choices are.
How did it feel to have these conversations?
Very difficult. It was very difficult, but looking towards the future, it's an important conversation to have.
During these difficult times, if a patient and their loved ones have knowledge of their wishes, and then that knowledge is conveyed to us as the treating team, that makes us feel that we're doing the right thing by the patient and the family by extension, because we are either doing lots of aggressive therapies, or we're not doing everything that we could do aggressively because we know that that is consistent with what the patient would want.
The hard choices become easier if someone has already thought about what they would like and what they wouldn't like. Also, I feel that I'm not actually driving a more clinically appropriate management plan. I'm actually supporting the patient in their choices.
The advanced care helps us to put in what we like or what we don't like, and plus also the children.
Yes.
It helps the children.
It is like saying, okay, do it your own way, like Frank Sinatra did. I did it my way. And it gives you that feeling of autonomy as well.
How did the advanced care planning team help you?
They spent time explaining the process and helped me understand how it's going to help us or help me.
And you got me to have a look at a pack of cards with the questions on it. What was important for me, which wasn't important for me. And by putting that all aside, it gave me a professional answer to put down on the paperwork.
I had been looking for this for a long time. I didn't know what I was looking for. So there I was.
If we don't know a patient's values and wishes, and we're going to put them through potentially invasive, burdensome treatments that have potential loss of dignity, we really need to know that we're doing the right thing by the patient and that that is consistent with what's important to them.
What would you say to others who are thinking about advanced care planning?
I'm definitely spreading the word to my friends. One-on-one, I'm talking to my friends. Family I've spoken to one-on-one to say, this will help you. It's helped everybody.
Make sure that you know what you want out of life and what best fits in with what you want, and plan for that.
Think about it, discuss it with your family and act on it.
Often we can make you better with lots of things, but often patients say, I don't want to go through that because I know what's involved. And having that conversation and information to hand and passing it on to your loved ones so we can talk to them at the time, that is really helpful.
That's my last chance to express my wishes before I depart. And what a better way to do it.
You've nailed it, Lorenzo. That's perfect.
Okay.
Yeah, absolutely perfect.
Call me Al Pacino.
I hope that's shown some of the stories, some of the challenges, as well as some of the benefits with advanced care planning. At Northern, we like to approach advanced care planning in 3 steps, and they fit nicely into the ACP acronym. First, we start with A, appointing another, C, chatting and communicate, and P, putting it on paper. And as you can imagine, having a discussion about appointing a medical treatment decision maker is a lot more easier, more curious, and a safer way to introduce advanced care planning, and probably something most people can conceptualize and articulate, as opposed to talking about an Advance Care Directive. Do you want a CPR, resuscitation? Do you want to go to hospital? They're not things people will understand or have ever thought about. So that's why we generally say start with the discussion about who is it that you would trust to make decisions for you, and would that person know what you would want? Because it's all well and good having somebody who you could trust, but if they don't know what you want, then they can't really act on your behalf. And that's why we say chatting and communicating is as important as any piece of paper. For those who have really strong views, putting it on paper, having a directive might be useful in helping make sure that we know what the goals and preferences are. We're going to talk about Mr. BC, and this is Lorenzo from our video. This is his story, and with his blessing, he's let us share his story. He's a 73-year-old chap from home with a housemate. He's been diagnosed with distal esophageal adenocarcinoma. He's tolerated chemotherapy, but he's about to have a pretty major operation. He's going to have an esophagectomy. He's pretty good in terms of medical history, home with a housemate. He's independent of his ADLs, but in terms of supports, he's got some family around Australia, but he's not in contact with any of them. So on our Mentimeter now, if that loads. Doesn't seem to be loading. Give me 1 second. Right. So that should have come up. For those who have joined who didn't get the QR code, if you go to menti.com, use the top number, that will get you onto this poll. And hopefully you can join that way. For anyone not, there's only 18 of you currently on the poll, so feel free to jump on. So menti.com and then put that number at the top. And so the question was, who is Lorenzo's medical treatment decision maker? And so most of you have correctly identified that he doesn't have a medical treatment decision maker. It's not his housemate or his GP, and so he doesn't have anybody. So in terms of appointing a medical treatment decision maker, your role as a medical professional practitioner is to assess the person in front of you's capacity to say, this person understands what this form is and what they're nominating. They understand the role of a medical treatment decision maker and they understand the consequences. The form does require a second witness, and that person is just there to witness the signature of the person. This person is signing this form. So in order to appoint someone, you still need to have decision-making capacity. So I want you to have a think about the case with Joseph now. He's a chap who I want you to think about who his medical treatment decision maker is. Would it be his wife? Would it be his wife who's currently overseas and is not available to be contacted? Is it his neighbor, a best friend? Would it be his paid carer, or who also happens to be a nurse, or is it his strange son? Could also be his sister, whom he speaks to weekly but lives currently interstate.
Not to worry.
For those who are following online, the scenario is that Joseph's been admitted to hospital, he's had a pneumonia, he's confused, he doesn't have decision-making capacity, he's not previously appointed any medical treatment decision maker. Well done for all those who have answered. It is his sister who is interstate. And we'll talk about why it isn't any of the other ones in our next slide. I want you to have a think right now if, for whatever reason, there was a noxious gas and you're unconscious and you can't make decisions for yourself, do you know who would make decisions for you? Who would it be? Is there somebody, have you appointed somebody, or under the law, is there somebody who would be your medical treatment decision maker? Some of you may have heard the reference to the hierarchy, and this is from the Medical Treatment Decision and Planning Act 2016. And so the Office of Public Advocate have this table which we refer to the hierarchy, and the default medical treatment decision maker for a person is the first person that's willing, available, and able. And the first person would be somebody who you've appointed. It may be a guardian appointed by VCAT. But for most people who haven't appointed anybody, it'll be somebody on this list. The important things are there needs to be a close continuing relationship. So the first person would be the spouse, partner, a carer not from a paid service, child, parent, or sibling. And if there's more than one, it would be the eldest person. So going back to Joseph's case, his wife, it would be his wife, except that she's unavailable and you can't contact. So she's not available or able. It's not the neighbor or best friend, because that's nowhere on that hierarchy is the neighbor, unless Joseph's appointed that person. It's not his paid carer, so we've said it has to be an unpaid service, so someone in that primary care role. And it's not the strange son, because you need to have that close continuing relationship. I've written at the bottom, do not use the term next of kin for the medical treatment decision maker. And I think that's a really important distinction. So much of the time when people come into hospital or in the media, we use the terms interchangeably. But from a law perspective and from a proper terminology, your next of kin will only make decisions after death. Decisions about funeral director, autopsy, a coroner's, registering the death. That is your next of kin. Your medical treatment decision maker is anybody who makes decisions when you are alive, and that's how we should be referring to that person. As you can see, you don't have to have a kinship relationship for someone to be your medical treatment decision maker. Joseph could have appointed his neighbor, that would have been his medical treatment decision maker, but it's not it might not be his next of kin. And you can see how that can cause some confusion, and we've had instances where we've called the wrong people. So I think it's really important we use the right terminology, and that is any decisions about medical treatment is your medical treatment decision maker. Who do we think would particularly benefit from appointing somebody? Somebody like Lorenzo, who didn't have a medical treatment decision maker. Did he want to appoint his housemaid? Was there somebody else he trusted? Sometimes we see on that list that it's the spouse or it's the eldest child, but your patient tells you, I trust the youngest daughter, she knows what I want. Under the law, the eldest child would be the person who would have the medical treatment decision-making powers, and they may not necessarily reflect the things that they would want. And so if it's somebody who's not that default person, it's really important to say to them, under the law, this is the person who would be making decisions for you. If it's not the person who you'd want, it's really important that you nominate that other person. And times when there may be confusion, so step families, different estrangements, it might be useful to appoint somebody to avoid any of that confusion. Some points. Previously, before the Medical Treatment Decision and Planning Act, you could appoint a medical enduring power of attorney. So we see that term used. But after 2018, you can no longer appoint a medical enduring power of attorney. You can only appoint a medical treatment decision maker now. And so if they had appointments prior to 2018, these are all still valid and we would treat them in the same role. But from 2018, you can only appoint a medical treatment decision maker. We've had instances where people say, I want to have them jointly appointed. Currently, you can nominate up to 4 people. On the most forms, it's 2, but you can find a longer form that has 4. But it's the person you put as number 1. That is the person who would act. And if we couldn't get in hold of them, we would go to appointment number 2. The people, when you fill in these forms, the people who are getting nominated don't have to be in your rooms with you. They can accept their nomination at a later point. So all you would need is the person who wants to nominate and a witness at that initial consultation, and they can take the form away. We've had people mail it interstate to family so they can sign and witness elsewhere. It doesn't have to be the same witness, and it can be completed at a later time. We think chatting is really important. So you've worked out who the medical treatment decision maker is. Now, I think you need to encourage them to tell that person, family, friends, their health service. For some people, religion is really important, and to chat and understand what are those things that are important. I think it's really important to learn. I guess this year's theme is about stories. learn the story. What do they fear? What are they worried about? What do they hope for? And these are the things that are going to be important to help you explain, help you talk about and navigate decision making. From a shared decision-making perspective, we've got two groups of experts, you as the clinicians and the patient and their families. They know the things that are important to them, their goals and preferences and what they would want. They are those experts. But you know what disease looks like, and you know what end-stage dementia will look like, heart failure, the natural progression of disease. And I think our role is to integrate those two groups of experts and create a shared decision in line with those goals and preferences with a recommendation that it aligns those. I think that's really important, providing that recommendation with what you know is what they would have wanted. And so our next question on our Menti is, what's the significance of these oral communications? That these oral communications are not legally valid, that they're less valid than written, that they're valid and need to be taken into account? Well, the problem is that you don't know who you can really trust in the family. It's great. I think most of you have hit the nail on that one, and that's that, as I've stressed, the communication, the discussion, that is as important as any document you could ever produce, and the conversation are as valid, and they should all be taken into account as well. So Lorenzo's thinking about doing an Advance Care Directive now. He's got a planned surgery. Have a think, does that change anything? He's about to have a major operation, but we don't really know how he's going to come out of it, how he's going to functionally be like. He's worried that he didn't want to appoint his housemate. He didn't want to put that burden on her. And so there was no medical treatment decision maker for him to nominate. So when we think about an Advanced Care Directive, it's one form with two directives, and that's your Values Directive and your Instructional Directive. Again, in order to complete this form, the person needs to have decision-making capacity. Think of your Instructional Directive as think of it as an instruction about treatment. What are they refusing or consenting to? We know Jehovah's Witnesses are great advanced care planners because they know the treatments they would want and not want. Instructional directives are legally binding. If I'm worried that my medical treatment decision maker may have different views, but I still trust them to make decisions, but I worry they may choose to do CPR on me when I wouldn't want, they can't override what you've written in your Advanced Care Directive. And that's the power, but that's also the challenge, because you don't want to write things that they may not understand and consent or refuse treatments they may have wanted. It's really hard for people to think about resuscitation, not going to hospital, those things. And so the instructional directive may have lesser value if people don't have really strong preferences. The values directive is probably where you should focus your time. Think about that as the place where they can talk about the things that add value to their life, the things that they care for, that they hope for, and that they find really important. You don't have to complete all parts of the form. You complete the parts that are applicable to you. And so for most people, a values directive is something tangible that they can think of, whereas that instructional component might be quite difficult for them to conceptualize. We've seen this form, Advanced Care Directive for adults, for someone signing on your behalf, and I just wanted to stress This form's intention, again, it's for somebody with decision-making capacity, but are not physically able to sign the form. So people who's had a stroke, motor neuron disease, and aren't physically able to, but they still demonstrate decision-making capacity. We've seen this form used many times when the person lacks decision-making capacity and a family member has completed this form on behalf of the patient. And you can understand where the wording may be quite tricky to follow, but from a legal perspective, these forms can only be completed by someone with decision-making capacity, and the purpose of this form is if you can't physically sign it. Who is it really important to consider writing an Advance Care Directive? Those who have really strong views about medical treatment. For Lorenzo, because he didn't have a medical treatment decision maker, doing an Advance Care Directive was really important because that would be his voice if he wasn't able to talk for himself. If you've got views that are different to your family, or if there's difficult communicating, being able to put this in place ahead of time might be quite useful. I've talked about what we do with those with decision-making capacity, but for those who lack capacity, either because they've never had it or they've lost it in the setting of acquired brain injury or strokes, we would say that you should recommend this form, which is what I understand to be the person's preferences and values. It's completed by family, by caregivers, medical practitioners, and acts similarly to a values directive, and is completed by someone else, similarly talking about the things that are important to the person. For Lorenzo, he didn't have specific things he wanted to write on his value directive, but the things that are really important he wanted to stress was that he didn't want to lose his autonomy or be dependent on life support. So that's what he wrote would be unacceptable. He wanted to donate his body to science, and so we helped give him some details, and he wanted to be an organ donor as well. So this is Lorenzo's instructional directive. Remember, he's about to have a major operation. We're not unsure how he would recover. And so he said he would consent to any treatment or any procedure that was pertinent to the surgical procedure for the esophageal cancer. But he refused any artificial intervention based on machine-based prolonging of life. He wanted us to use do not resuscitate principles. And we asked him specifically, would you want to go to intensive care? Lorenzo, if you got better, you went home and you came back a month later with a pneumonia, would you want to go to ICU? Would you want things like non-invasive ventilation or intubation? And he was adamant he wouldn't want that treatment. He was very much of the mindset that I've lived a good life and that those treatments are not what I would want. And so he was very articulate in what he would want. Not all of our patients will be like that, but these are some examples for those who are very adamant on what they want. These are the things you could put in an Advance Care Directive. On this last little bit, I wanted to touch on goals of care and how that intersects with advanced care planning. And so advanced care planning we've talked about is undertaken by someone with capacity, planning for when they can't speak for themselves. Think of your goals of care as a medical treatment order. It's completed by a doctor in consultation with the patient, their medical treatment decision maker. It's a care now plan, planning for those urgent situations. I'm not sure how many of you are familiar, but we've got a resident in hospital. We have our goals of care. It's well established in residential care, our goals of care setting. And we've newly introduced a home-based goals of care as well, and I'll touch onto those. But as you can imagine, in the hospital on a Saturday night at 2 a.m., I don't have time. When my patient collapses in front of me, there's no time to interpret an Advance Care Directive. I want to know, are we doing CPR? Are we calling a code blue? Are we getting a MET call? Similarly, in residential care and at home, we want to know, are we doing CPR? Am I calling the ambulance? Are we going to hospital? And those decisions need to be made pretty promptly, and it helps integrate what we know of somebody's preferences and values, so their directives, their advanced care plans, but it also puts into context that medical trajectory and what is medically feasible, again, alluding back to that shared decision-making process. Somebody with capacity, you would make that decision with the patient and in order to create that treatment plan. Somebody who lacks capacity, you would look at their instructional directive, their values directive, and make that consultation with the medical treatment decision maker and the patient if they're able to. This is our residential goals of care. Again, stressing that though we want to know, are we doing CPR? Are we going to hospital? Are we calling the ambulance? Are we trialing treatment at the facility? They're the things we want to know pretty quickly if we need to make a decision. Goals of care are a way of communicating goals and preferences and putting into action escalation plans as well as your Advance Care Directive. This is what our home-based goals of care looks like. There's a big focus on CPR as well. And then similarly, are we doing CPR? Are we going to hospital? Or are we trying to avoid and having treatments at home? I wanted to share two stories with you for some residents who I met through my virtual specialist clinic. JE was 54 from a supported disability accommodation. She had end-stage multiple sclerosis and had recurrent UTIs. She was quite frail, needed support for her personal ADLs, and she had a prolonged admission at Western Hospital. I'm not sure if you are aware, but the disability sector, it's quite hard to navigate where there may not be a nurse there at all times. There may be just care workers. And in that instance, they are obliged to do CPR until until the family tell them otherwise. So we needed a plan. How would we support JE in her supported accommodation, planning for that deterioration and to prevent burdensome, distressing treatment that she didn't want or her family thought that she didn't want and that had already been discussed. And so the ceiling of her treatment was going to be oral antibiotics. In my clinic, we discussed the role of community palliative care. The home itself would not be able to facilitate subcutaneous injections, and we completed a home-based goals of care as a form of communicating her wishes, her family, her medical treatment decision maker wishes, and preventing those burdensome treatments that weren't in line with those goals and values. And so we wrote not for CPR and for a trial of oral antibiotics. The back of the form allows you to document how you came to your decision-making process, what the escalation plan is, and what the plan would be if someone were to deteriorate. BS was an 80-year-old gent from Home Alone. He had a progressive neurological disorder, which was worrisome in that it was going to compromise both his cognition and his physical function. His daughter was his medical treatment decision maker, and her biggest concern was that if her father fell at home and the paramedics came, that they would do CPR on him. BS was adamant that he probably had borderline decision-making capacity, but doing CPR would not be in line with what his daughter knew was important for him. And so we used our home-based goals of care as a means to articulate those wishes. So again, not for CPR, we've ticked that should have non-burdensome life-prolonging treatment. And you can see you can use the form to articulate the same conversations you would have in an Advance Care Directive, putting it as a medical treatment decision, a medical treatment order. And so if I told this family you should leave a copy with the medications, leave a copy on the fridge. And if a paramedic were to see this, they would clearly be able to know that we wouldn't be doing CPR. If we could treat BS at home, that is the preference. But if we got in a position where he was getting worse, they would be open to palliative care as well. And I guess that was something reassuring for the family to know, and a way of communicating those wishes where an advance care directive may be too burdensome, may be distressing to go through that process, or when the person may lack decision-making capacity and so can't do an advance care directive. We developed our home-based goals of care because we are caring for people who are quite frail in the community, and that there needed to be a way of clearly communicating agreed treatment limitations. This form is not for everyone. There should be no conflict in the decision-making process. And so, as much as sometimes we want to avoid people coming to hospital unnecessarily, this is not a form where we can just complete and say you can't come back to hospital. It's for those people who have strong wishes, who want to articulate a clear plan if they were to get worse. It can be completed by the hospital, GPs, as well as any specialists. And that's available on our Northern ACP website as well. I wish there was a central place we could put all our documents that we could see. The limitations of My Health Record is that the patient has to log into their own account and upload an Advance Care Directive or Advance Care Planning document, and navigating that is quite difficult at the best of times. So we generally say keep a copy of your medications. That's where the paramedics will look. Keep a copy on the fridge. Make sure your GP, your health services all have a copy, and that your medical treatment decision maker has a copy as well. Our Northern Advanced Care Planning Service can help our community complete these forms, continue the discussion, and to help just navigate that process. We can appreciate that these are difficult but also very time-consuming conversations, and they're not things that can really be rushed. And so our service can help support that. If you go to our Northern ACP website, there's a referral form. We've got our email, and you can give us a call at any time. But I think it's just really important to remember that not everything needs to be done at once, and that as much as I wish I could just book someone in an hour session and get all these ticked off, that's never going to happen. Our role is to open the conversation, to invite communication, but there's a majority of people who will never be able to articulate and participate in advanced care planning like we would hope, even those who have serious illness. I myself have tried to have a chat to my parents about doing their wills, thinking about doing an advanced care plan, and that I am shut down at the very instant of the discussion. So I think our role is to open the conversation, and for those who want it, those who really need it, we should invite that conversation to help those, and that's where we would get the most value. As I mentioned, I run the palliative care and advanced care planning clinic, and separate to those case conference and co-consults, you can book your patient in as a direct consult, so you don't have to be part of the consultation. I'm able to spend 40 minutes talking about what future care planning would look like. I can't sign any forms online, but I can complete a goals of care, but also just open that conversation, have that time for them to ask questions and help navigate that process. And so I'd welcome any referrals if you felt that useful. I've had a GP join me as a case conference, and we work together to complete the form and explain that to the patient. The Office of Public Advocate are a great source of information if you need that, and they've got a good web tool that helps you work out if there's tricky cases of consent, or if you're not sure if your patient or resident can consent. So they're the main things I wanted to share. I think opening the conversation is everyone's business, and planning for that deterioration is important. And for those that you can use telehealth, feel free to book them into my clinic. And for those who need that in person, probably coming a referral to our Northern Advanced Care Planning program might help as well. So I'll just go to the next slide. So Morgan, I'll hand back over to you.
Thank you. That was fascinating. I mean, I definitely learned a lot. Well, I suppose it's one of those things where it's just opening the door to the conversation, and then there's a lot of paperwork. So any kind of advice which you've given around troubleshooting those, extremely useful. And I to everyone on the call and to anyone who's not here, but if you have colleagues who you think might be might find this particularly helpful, please do look at booking in with Hao and just having that conversation as a team, either with you and the patient and Hao and some other people, but otherwise just as a starting point, because it can be difficult to start those conversations, and it's nice to have other people in your corner when you're doing it. If anyone has any questions, I believe that the audio is muted for people who are attending. If you have any questions, pop them in the chat. I'm very happy to answer them. Oh, sorry, ask them. I definitely can't answer them, but I can ask them, pal. Maybe just a few minutes of that. I can see a few typing signals coming up, so just give me a moment. And also there's the link for the CPD. I've put a link in the chat, and also there's the QR code there as well.
So there was the question about advanced care directives for those with dementia. So I would say fill in what I understand to be the person's preferences and values. But if you need that plan ahead of time, that escalation plan, our goals of care is probably the best way to document and actually make it quite easy for people to understand what we would do if this person became unwell. For those in residential care, you could fill in one of those forms, or you would fill in a home base for those at home. Some of the residential cares don't use the goals of care, but I think whatever way the home does it, a way of just communicating what we would do when someone becomes unwell, that is the most important part.
I can see one's coming. I think you're just reading it as well.
Yeah. So I guess the question is, if people complete these documents, so nominating a medical treatment decision maker or an advanced care directive when they didn't have capacity, how can this be nullified? I guess it's quite tricky. I guess the role of the first witness is the medical practitioner or someone who signs affidavits. Their role is to say this person had decision-making capacity at that point in time. You're really questioning, you'd hope that they have some form of documentation of how they assess capacity, understanding that capacity can change over time, it can fluctuate. One day you can have it, one day you may not. And so if if it's, I think it's going to be quite tricky to say that that point in time in the past, this person did not have capacity. To actually nullify the actual form, I guess it depends on what you want to do. If the person doesn't have any more decision-making capacity, then they can't nominate someone else. So usually to nullify an old form, they could appoint somebody else. The person can choose to revoke an old form as well. But it's quite difficult to get someone appointed if they don't have any decision-making capacity. And so that's why we generally say to have the discussion early when they can be part of it. I don't think I've really answered the question, but I guess it's just, I'd hope that the person who's signed it in the first place has assessed decision-making capacity. And I think for those borderline cases, you might just have to trust that they did and they've done all the right things to assess capacity at that point in time.
I have
Alex,
a question.
has got your hand up? Yes.
Oh yeah, Alex, over to you.
Hey, so sorry, I'm on a Mac and I can't seem to navigate from the window to just the messaging thing. So my question is, who is an appropriate witness? So when patients sign the documents in front of me and I sign my part, I've understood different messages from different people. So am I allowed to get a nurse, a practice nurse, to come in and countersign as the witness?
Yes, absolutely. Receptionist, nurse, any other employees fine to sign. I can't remember exactly. Don't think family members can sign any relationship, but it's their purpose is purely to say that this patient in front of me actually signed the form, and that's their purpose to, I guess, similar to when you're doing a stat dec or when you're signing something that. But yes, anyone else in the practice can definitely be the witness.
In a nursing home situation, is it the same? Because I've been told in nursing homes that the RACF nurse can't sign. I don't know if that was an internal policy or some sort of law.
It's not law. If it would be anything, it might be a policy, but there's no legal reason they couldn't sign.
And we might throw the last question to Lily, and then I'll wrap it up. Thank you.
Thanks very much for the presentation tonight. I was wondering if you'd be okay with sharing the slide that had some prompts for patients, because that's what I often struggle with in advanced care planning, is questions for patients to make them reflect on their values and their preferences. I sometimes struggle with those prompts, so it would be really helpful to have that.
Morgan, are you sending out some resources after? So I'll happy to share the slides. I'll share in the video. Julie alluded to having some cards, and so I'll send the link from Palliative Care Australia. What I've also done in my clinic is order, the cards are free online to order. And so it's a pack of 30 to 40 cards with statements, the things that are important. And we usually get the person to make 3 columns. These are really important. These are a bit important. These are not important. And that's a way for them to articulate and put into words the things that are important. They're free. They'll deliver to the person's home. And so I'll put a link with that in the resources that you can use. It might be handy to just have them in your office as well, or just having a set to give away when they're thinking about it.
Thank you, that would be great.
And we can, we'll definitely follow up and get some information out. So I think there's one more slide which just says that something's coming up.
There is another webinar coming up.
So we'll send out some information about this as well, and really appreciate everyone spending some time with us tonight. And I'd a special thanks for obviously to Hao with his expertise and time and passion in this area as well. So thank you very much. And yes, look through the virtual specialist consults on the website if that's helpful. Feel free to send us any questions you have, book in with any of the clinics, and I hope that you all have a lovely evening. Thank you.